You are very welcome to this talk. In this episode, the crux of the talk would be on neonatal umbilical problems, which is one of the subsets of neonatal problems for which the parents they seek medical advice, and usually there is a lot of anxiety and a lot of parental concern attached to these presentations. And by the way, if we haven't met before, then my name is Dr. Sayed Kazmi, and you are watching Professional Pediatric Talks with Dr. Kazmi, which is my YouTube channel dedicated for those who are learning pediatrics. So without further wasting our time, let's dive in and get started. So as I told you, one of the common reasons for neonatal visits to emergency departments and pediatrician clinics are umbilical problems in neonates. And most of these umbilical problems, they are benign in nature, but they cause great parental anxiety and great parental concern. And the issues are quite broad. They range from what we call as an oozing umbilicus, in which the complaint is that there is fluid or some colored thing coming out of the umbilical stump. The other set of problems could be bleeding from the umbilical stump. Again, this is a great cause of concern and anxiety among the parents. The third is redness. So redness means that the area around the umbilicus that becomes red in color. In other words, there is inflammation of that particular area. Another subset of problems is swellings of umbilical area. So these are mostly hernias or some other congenital problems which can present as swellings in the umbilical area. Last but not the least, there is an issue which is a bit rare, which is known as delayed cord separation, which can have different meanings. So let's take them one by one. So we will start by the first subset of problems, that is oozing from umbilicus. Now, oozing from umbilicus is relatively common. Around 4 or 5% of the neonates, they might present with this complaint. Now, in most of the cases, the oozing is caused by granulomatous growth in the umbilical stump, which we call as umbilical granuloma. So this is basically a granulation tissue. And usually why this occurs is because of the localized trauma. The trauma is one of the inciting factors for granulomatous inflammation or granulomatous malformation. So what happens because of localized trauma, which might be because of the rubbing of the clothes or because of the diapers, there is growth of the granulation tissue, and that granulation tissue then oozes. It can bleed as well, but in most of the cases, it would ooze. So the complaint is usually that around the umbilicus, there might be a pinkish flesh-shaped structure, which is either oozing pinkish white or sometimes yellowish fluid, and this actually stains the inner side of the clothes or the inner side of the diapers. For example, in this diagram, if you see this rounded strawberry-like mass, pinkish raw mass arising from the umbilicus, this is umbilical granuloma because there is granulation tissue, and this granulation tissue, because it's quite vascular, this actually secretes a lot of fluid, which might be yellowish colored or sometimes might be pinkish colored, and it usually stains the inside of the clothes or the diapers. You can see this is a diaper, and I told you most of the times this granuloma is because of local irritation, which might be because of tight diapers or because of the irritation of the edges of the diaper or because of the clothes. Here you can see another flesh-shaped growth from the umbilical stump, which is causing oozing, and this is umbilical granuloma. So umbilical granuloma is one of the most common cause of oozing from the umbilical stump. Now the question is, how do we treat it? Now in certain centers, they use silver nitrate application. So silver nitrate, which is also known as chemical cauterization. So a chemical which is known as silver nitrate is repeatedly touched to the umbilical granuloma. So what happens is that there is a chemical inflammation and coagulation of those vessels which are inside the granuloma, and they coagulate over a period of time. So usually silver nitrate is applied twice daily. But one thing is very important. If you are doing this procedure, it is very important that you have to be very careful that you only apply the silver nitrate on the tip where the granulation tissue is, because if you touch the surrounding area, then the surrounding area will also get chemical inflammation. So a lot of care has to be practiced when you are cauterizing it chemically with silver nitrate. These days, another safe method of drying out umbilical granuloma is the application of sea salt. Sea salt is basically more stronger than the table salt, and because of its osmotic properties, what it does, like if twice daily the parents rub sea salt on the umbilical granuloma, it would cause, it would draw water out of it. So it would cause dehydration of the umbilical granuloma, and as a result, it would die over a period of time. It would coagulate, it would eventually heal. So sea salt application or silver nitrate application are the two modalities of treatment for umbilical granuloma. But at the same time, there is a caveat here. Though most of the cases would be caused by umbilical granuloma, you have to be careful that the discharge itself is not urine, because if it smells of urine, if it's got a strong smell, then it might be urine. And if urine is oozing from umbilicus, it might be an indication that there is a patent urachus. So patent urachus is a fetal remnant where the bladder was connected to the umbilicus, so it involutes. Sometime it can remain patent, and in that particular case, the urine would leak through the umbilicus. So if it smells of urine, you have to ensure that it is not a patent urachus, and obviously it has to be diagnosed with radiological studies where a dye has to be injected, where it goes into the bladder, and then they see if it is coming through the umbilical stump or not. If it is smelling of fecal matter, or if looks like fecal matter, then you also have to ensure that it is not a patent omphalo mesenteric sinus or vitello-intestinal duct, as some call it. So if there is a patent vitello-intestinal duct or omphalomesenteric sinus, then in that case there is an abnormal connection between the intestines and the umbilicus, and that would be draining fecal matter. So either it's a patent urachus or whether it's a patent omphalomesenteric sinus, in both cases you have to take the opinion of a pediatric surgeon, because these things have to be excised and repaired. Okay, moving on. The second category of neonatal umbilical problems is bleeding from the umbilical stump. Again, this bleeding could be either because of localized trauma, it could be because of the umbilical granuloma as well. I told you that in most of the cases, umbilical granulomas, they ooze a clear or straw-colored fluid, but sometimes because they are vascular structures, because of local irritation or localized trauma, they can bleed as well. So if the underlying tissue is granulation tissue, it's an umbilical granuloma, and if it is bleeding, then obviously, as I told you earlier, it has to be treated either with chemical cauterization with silver nitrate or by application of sea salt, or sometimes if it is like a resistant one, then it can be surgically excised. But it's also important that you have to ensure that there is no surrounding inflammation, because that is a serious condition. If there is redness around the area, cellulitis, and obviously that would also lead to inflammation and dilatation of the blood vessels, and sometimes superimposed trauma on that can also cause bleeding. So it's important that you ensure that there is no infection, cellulitis in the surrounding area of the umbilicus. If it is a frank bleeding, like if there is a lot of bleeding, then it's important that you rule out two conditions. One is hemorrhagic disease of the newborn. Now, this is a rare condition these days, obviously, because of, newborns are given vitamin K at the time of birth. But sometimes in developing countries, babies can present with hemorrhagic disease of the newborn, though in such cases, either it's an early presentation or late presentation of hemorrhagic disease of the newborn, they might be having other signs and symptoms of the hemorrhagic disease of the newborn. Like, for example, they might have bleeding from other orifices, or they might have large, bruising or purpuric spots in the skin. The other one thing which can be quite treacherous is factor 13 deficiency. So how factor 13 deficiency presents, very interesting. These babies are absolutely fine. The umbilical stump is drying, it is getting brownish and black, and then after a few days, probably second week, it starts bleeding, and then there is no surrounding infection like cellulitis or things. The baby is otherwise healthy, and even if you do a coagulation profile, all the tests are normal. So prothrombin time, partial thromboplastin times, INR, everything is normal. While in case of hemorrhagic disease of the newborn, prothrombin time is elevated, obviously, because prothrombin time depends on formation of vitamin K. While in factor 13 deficiency, usually there is late oozing after healing of the umbilical stump, and in most of the cases the coagulation profile would be absolutely normal. So hemorrhagic disease of the newborn and factor 13 deficiency you have to consider if you are confronted with a situation in which there is frank bleeding from the umbilical stump. I hope that is clear to you. Okay, moving on. Redness of the umbilical stump, or the area which is surrounding the umbilicus. Now, redness has to be taken a bit seriously. First thing, you have to ensure whether the area is red or not. For example, if you look in this picture, you can see that there is redness around the umbilical stump. So the umbilical stump itself is getting dried. You can see there is a clamp here, but there is some redness. So you have to see whether there is induration of this area or not. So if there is induration with redness, it means that there is infection here. In other words, it's cellulitis. And cellulitis, is infection of the subcutaneous tissue. So subcutaneous tissue, if it gets infected, most of the time the organism might be staphylococci or streptococci. But why it is taken seriously is because umbilical stump has got remnants which are connecting to the intestine and to the bladder. So the infection can track into those, involuted structures and can go into the bladder, or can go into the bloodstream, or can go into the intestine and can cause frank septicemia. So it's very important that if you see a baby who has got redness of the area surrounding the umbilicus with induration, you take it as omphalitis, and that has to be taken seriously because these kids need systemic antibiotics, they need intravenous antibiotics. Remember, in neonates we give intravenous antibiotics because oral absorption is very, very erratic. So in these two pictures you can see there is area of redness, and if you feel with your finger you will feel induration as well. You can here see an infected umbilical stump along with redness of the surrounding area, which means the cellulitis is spreading. So the earlier you pick up and the earlier you start intravenous antibiotics. Obviously you have to take cultures, blood cultures, and do your routine blood tests and other things, but after that you have to start IV antibiotics depending on whatever your trust policy is. But it is again, I'm emphasizing this thing, that it has to be taken seriously. So if there's omphalitis, straight away you have to cannulate the baby, you have to do the routine test with all that what you call sepsis screen, and you have to start them on intravenous antibiotics. Okay guys, moving on. Now coming to the fourth category, which is swelling of the umbilical area. Now, swelling means that the umbilical area has got a swelling. It could be a subcutaneous swelling, or it could be swelling caused by intestinal organs. The most common cause of umbilical area swelling is umbilical hernia. So you can see that the umbilical stump is protruded forward and it has got soft squishy contents inside it, and that's soft squishy contents are intestines. Now, why umbilical hernia occurs in babies is because of simple laxity of the abdominal wall. So a little bit of increase in the intra-abdominal pressure, the part of the intestine can come. You can reduce it, but because the abdominal musculature is lax and there is a bit of gap in the muscle, so the intestines, they spring back into this particular area. Umbilical hernia is sometimes associated with certain conditions in which there would be more laxity of the abdominal wall musculature, like for example Down syndrome, hypothyroidism, but in that case you will see other features which are pathognomonic for these two conditions. Nevertheless, in most of the cases it's just an incidental finding. How do we treat it? We don't treat it simply, we just have to wait. By 2 years of age, 99% of these umbilical hernias, they have reduced by themselves. In certain countries, there's a practice that they put coins, big coins, just try to strap the coins around the umbilicus. That's not a good practice because it can cause pressure necrosis and pressure breakdown of the tissue, and that can cause secondary infection. So it's not a good practice. You just have to wait. You just have to give reassurance to the parent. Obviously, by 2 years of age, if it doesn't reduce, which can happen in around 1% of the babies, then obviously the surgeons can do herniorrhaphy and repair it. But as I told again, majority of these swellings, umbilical hernias, are self-corrected by 2 years of age. Two other important swellings which are rare but are quite serious are omphalocele and gastroschisis. Now, these two conditions, in both these conditions, there is like protrusion of abdominal contents, intestines in most of the cases, outside of the abdominal cavity. Omphalocele is a condition in which the abdominal organs are protruding, but they are covered by a thin membrane or sac. So remember, this is very, very important. If the contents are covered by a sac, that is omphalocele. Now, why omphalocele occurs? Well, again, during fetal development, as the intestines, they come out of the abdominal cavity and then they go back. There is rotational and they go back. Sometimes that fails. So what would happen is that the contents would be trapped outside the abdominal cavity because they fail to return back and they are covered by that membrane. So that is known as omphalocele. So if omphalocele is again, it's important that you prevent infection because the intestinal gut or intestinal component are exposed to the outer air, and that a lot of bacteria. So you have to make sure that it doesn't go inside. So you have to cover it properly, and then you refer these babies to the pediatric surgeons, which have to do a repair in which the intestinal contents have to be taken back into the abdomen. Gastroschisis is just like omphalocele, but the difference is that rather this contents coming out of the umbilical stump, they are coming out of the abdominal cavity slightly to the right side. So it's not actually coming from the umbilicus, it's slightly to the right side of the umbilicus. And the contents might be stomach, might be intestines, any part of the abdominal cavity. They are not covered by the membrane. So remember, I will just put it, this one is covered by membrane, covered by membrane. So if it's covered by membrane, that is omphalocele, while this one, gastroschisis, is not covered by membrane. So obviously, this is more dangerous because the organs here are exposed to the bacteria and can quickly get infected. So obviously, this type of kids, they have to be cannulated. You have to start them with systemic antibiotics to prevent any infection. Obviously, they need to be immediately referred to the pediatric surgeon so that they can take care of these like surgical correction. In this particular child, you can see that it's not only gastroschisis. You can see that the baby has got dysmorphic features. He's got bilateral cleft lip and bilateral and probably cleft palate as well. And this is very much pathognomonic of trisomy 13, which is also known as Petau syndrome. So Petau syndrome, which is trisomy 13, because there are three, parts of chromosome 13. With that, gastroschisis is quite common. So remember, umbilical swellings, most of the cases will be umbilical hernia, but then you should be able to differentiate between omphalocele and gastroschisis. Moving on to the delayed cord separation. Now, most of the cases, umbilical cords, they get dry and they usually fall somewhere between 1 to 2 weeks after the birth. So between 1 to 2 weeks after the birth, they usually fall off. Now, if they are not falling off, if they are attached to the umbilical stump, and especially if it doesn't fall after 3 weeks, then you have to think why this is not falling. There are certain conditions which are associated with that. Number one are urachal abnormalities. So I told you earlier, like a patent urachus or something that can be associated with delayed separation of the cord. But most importantly, sometimes the delayed cord separation might be the earliest sign of primary immunodeficiency disorder. And one of the primary immunodeficiency disorder which can present that way is known as LAD, leukocyte adhesion deficiency. The leukocyte adhesion deficiency, in very simple words, it is a condition in which the leukocytes cannot adhere to the pathogenic organisms. Obviously, in order to engulf bacteria or other pathogenic organisms, the leukocytes, the white blood cells, have to attach with the organism and then they have to engulf that. So if they are not able to attach, then obviously they are not able to eat those bacteria. So those bacteria would thrive and they would cause infection. So most of these infections, because the white blood cell, they go into that area, but they're not able to attach. So usually these types of infections, they do not have pus in that, because pus is caused by dead white blood cells, and dead white blood cells occur when they engulf these bacteria. So when they are not able to engulf that, then obviously there is no pus formation. So leukocyte adhesion deficiencies are different types: LAD1, LAD2, LAD3. At the moment, I'm not discussing leukocyte adhesion deficiency. I have covered that in my immunodeficiency disorders lecture. But anyhow, the thing is that in leukocyte adhesion deficiency, usually if the area is inflamed, there is no pus formation. And one of the earliest signs of leukocyte adhesion deficiency, which is a primary immunodeficiency disorder, is delayed separation of the cord. So remember, after urachal abnormalities, the second common cause of delayed separation of cord, if the cord is not falling by 3 weeks of age, it can persist even beyond that, then you have to consider leukocyte adhesion deficiency disorder. So these were few of the neonatal umbilical problems which I have covered in this particular lecture. I hope you have understood, because I tried to explain them in very simplified language. Still, if you have got any questions, or if you've got like anything which is not clear to you, then you can put your question down in the comment section below, and then I will try my level best to answer those questions. Now, if you have liked my videos, then please give me a thumbs up. And if you haven't subscribed to my channel, then please do subscribe and share my videos with your friends. Okay, have a very good day. Bye-bye.